In this lecture, we will discuss accelerated idioventricular rhythm, including its origin, mechanism, potential causes, clinical significance, and EKG features. Accelerated idioventricular rhythm is simply a fast ventricular escape rhythm. In adult patients, the rhythm is defined as a ventricular rhythm that is faster than sinus rhythm, but just below the threshold of what we would consider ventricular tachycardia. So as you can imagine, this accelerated idioventricular rhythm occurs when the rate of an ectopic ventricular pacemaker exceeds that of the sinus node. It is often associated with an increase in vagal tone and a decrease in sympathetic tone. The mechanism appears to involve enhanced automaticity of a ventricular pacemaker, although triggered activity may also play a role in settings such as myocardial ischemia or digoxin toxicity. So if you look here, again, we're talking about our ventricular rhythms, and we're having this rhythm come right from our ventricles, okay? The only difference here from our idioventricular rhythm is now it's accelerated, okay? So we have an accelerated idioventricular rhythm, a rhythm coming from the ventricles because those above it are not firing in its place, and because now we have this also occurring in the setting of increased vagal tone and decreased sympathetic tone. So you can imagine maybe our sinus node and AV node are working fine, okay? So it's not really an escape rhythm, although there's some ectopic focus here in the ventricles that gets some excitability and enhanced automaticity and starts to take over the rhythm of the heart. Now, one of the most common causes in clinical settings in which we can see this rhythm is in the setting of acute myocardial infarction, especially during the reperfusion phase. So that's one of the most common scenarios. Other causes and settings include cardiomyopathy, congenital heart disease, myocarditis during ROSC or return of spontaneous circulation post-cardiac arrest, the athletic heart, anemia, hypokalemia, and drugs such as beta agonists, or we can see it with digoxin, cocaine, opioid, or volatile anesthetic toxicity such as desflurane, okay? Now, so clinically speaking, the rhythm is typically well tolerated, benign, self-limiting, and not associated with any significant hemodynamic instability. Furthermore, it does not progress to ventricular tachycardia or ventricular fibrillation oftentimes. Therefore, treatment is often not required, and management should focus on treating the underlying cause, such as correcting any electrolyte disturbance, right? So if the patient has an electrolyte disturbance, we mentioned here that one of the causes was hypokalemia, so you'd want to correct that, or restoring myocardial perfusion, okay, in the setting of ischemia or infarction. Okay, so what can we expect to see on the EKG? In general, if you look at the EKG and you see a regular rhythm that has no identifiable P waves, as well as at least 3 wide, bizarre appearing QRS complexes, then you're likely dealing with some sort of ventricular rhythm. The QRS interval is prolonged, reflecting the ventricular origin of each beat, and this is because intraventricular conduction is occurring outside the normal conduction system by a cell-to-cell depolarization, which is a slower process and prolongs ventricular depolarization. So by now, you should be able to know that if you see these wide complexes, one of the main things you should be thinking is a ventricular origin, okay? So we have this coming from our left ventricle in this place. Remember, we're outside our normal conduction system, so all this conduction throughout the ventricles will be a lot slower, okay? The cell-to-cell depolarization, and because it's slower, it's going to prolong our QRS complexes, okay? So our QRS complexes representing ventricular depolarization will be prolonged for this reason. Okay. We also mentioned there's no P waves often present because it's originating from the ventricles. Okay, so it's not the sinus node that's originating or where the rhythm is coming from, but from our ventricles. And because of that, we don't often see P waves. Now, one thing to note is that it's possible to have retrograde capture of the atria, okay, like those other ventricular rhythms, in which you can see a P wave with an abnormal axis occurring after the QRS complex. This is less often seen, but still possible, okay? So like our other ventricular rhythms, we can have retrograde activation of the ventricles or of the atria, and in such cases you may see a P wave that occurs somewhat after our QRS complex, okay? And that P wave would have an abnormal P wave axis. Now, there's something called isorhythmic AV dissociation. In such cases, there's AV dissociation, meaning that the atria and ventricles are pretty much not talking to each other, they're not in sync. And in this case, so there's AV dissociation with the sinus and ventricular complexes occurring at the same rate, okay? That is isorhythmic, occurring at the same rate or rhythm. So we're right here where we're looking at this isorhythmic AV dissociation, and we're saying that the sinus and ventricular complexes are occurring at the same rate. And because of that, the sinus P waves may actually be buried within our QRS complexes, or T wave. So in other words, we have a rhythm. Okay, so imagine that we have AV dissociation, so there's maybe a block here, so nothing can get through our AV node, but we have our sinus node firing and our ventricular ectopic focus also firing. Okay, and they're actually going at the same rate. Okay, remember our sinus fires between 60 and 100. And we're saying that our accelerated idioventricular rhythm is also within that range. Okay, so if it's firing within that range, we may actually have them occurring at the same rate. And because of that, if you have them occurring at the same rate, we may actually have sinus P waves. So imagine we have our upright P waves. Imagine these as sinus P waves that are upright, but they're buried within our QRS complex, occurring at the same point throughout. And we also have our QRS. So we have ventricular depolarization represented by our QRS complexes throughout, and then we also have these small P waves that are occurring within our QRS complex at the same point. Okay, we call that isorhythmic AV dissociation. So just something a little more advanced, but something I think you can handle. Okay, another thing to realize here is that this rhythm, this accelerated idioventricular rhythm, is a regular rhythm. That means that the intervals between each complex are consistent throughout. So if we look at our main complexes here, which are these big R waves, you'll notice that each one is the same throughout. Okay, all these R to R intervals have the same distance throughout them if you were to measure them. Okay, and because of that, we call this a regular rhythm. Now, what differentiates this ventricular rhythm from other ventricular rhythms is the rate. If you recall, the normal intrinsic rate of ventricular pacemaker cells is generally less than 40 beats per minute in adults. This corresponds to an escape interval of about 1.8 to 2.2 seconds between complexes. Therefore, if we had a ventricular rhythm at a rate of 40 beats per minute or below, we would be thinking of an idioventricular rhythm. However, in this case of an accelerated idioventricular rhythm, the rate exceeds the intrinsic rate of the ventricular rhythm, but is just below the threshold of what we would consider ventricular tachycardia. The actual threshold range for this is actually disputed. Okay, some say that the range is for the accelerated idioventricular rhythm is between 40 and 120. Okay, but it's anywhere between 100. Okay, some will say 40 to 100. Okay, in other words, say you have we're saying that less than 40, we have this idioventricular rhythm. Okay, and if we say between 40 and 120, we have this accelerated idioventricular rhythm. Okay, and then greater than 120, we'll start looking at VTAC. Okay, so we're going to use this 120 as our upper threshold. So if we look at the rate in this rhythm that we have here, remember, because this is a regular rhythm, we can count the number of the thick lines between each R wave, okay, or between our R1, the consecutive one, and then divide that by the number by 300, okay, or 300 divided by that number. So that'd be 1, 2, 3, 4. Okay, so about 4 thick lines, which is 300 over 4, which is 75 beats per minute. Okay, again above our idioventricular rhythm and in this range of an accelerated idioventricular rhythm. Okay, so that's the rate that's really defining the cutoff of these things, just like when we talked about any junctional rhythms. Now, one final thing here is that you may see fusion or capture beats. Capture beats occur when the sinus node transiently captures the ventricles to produce a QRS complex of normal duration. And fusion beats occur when a sinus and ventricular beat coincide to produce a hybrid complex of intermediate morphology. And just as the name implies, the sinus and ventricular beat fuse together. This is something we'll get into more detail when we start talking about ventricular tachycardia, but it's something I want you to be aware of for now, okay? You may see it in these cases if the rate gets a little higher, but not often so. All right, so hopefully this wasn't too difficult. Great job if you're really understanding all of this. Let's quickly go through our chart before we end here. So an accelerated idioventricular rhythm is the result of an ectopic ventricular pacemaker that's firing above the sinus node, okay, or at least outcompeting. So if the sinus node is firing at 62, it may be firing at 70. And because the fastest pacemaker controls the rhythm of the heart, it may be this rhythm in the ventricles that sets the pace. Now, oftentimes, there's an increase in vagotone or a decrease in sympathetic tone associated with this rhythm. The mechanism is often due to enhanced automaticity. You may see triggered activity in ischemia or digoxin toxicity. We mentioned a number of causes. Clinically, this is often well tolerated, benign, and self-limiting, and doesn't require treatment. We talked about isorhythmic AV dissociation, in which the sinus and ventricular complexes occur at the same rate. So sometimes we can see those P waves that will be buried within the QRS complex or T wave. We mentioned these fusion or capture beats that we'll talk about more when we talk about VTAC. Okay. Now, in terms of this rhythm, the regularity is regular, meaning that our intervals are consistent throughout. The rate is between 40 and 120. Okay. In terms of the P waves, there's often no P waves unless they're buried within our QRS complex or retrograde. Okay, so if there's no P waves, there's often no P to QRS ratio and no PR interval. Okay, and that's obviously if you have that retrograde conduction or isorhythmic AV dissociation, you may see something like that in which the P to QRS ratio changes. Okay, now in terms of the QRS interval, this is one of the main things is that we're going to see a prolonged QRS interval. Okay, the width of the QRS complexes are prolonged because we're originating within our ventricles where we have that slow cell-to-cell depolarization. Okay, and you usually want at least 3 wide QRS complexes with abnormal morphology. There's no grouping and no drop beats. Okay, so the main thing here is that you have this regular rhythm that's occurring above the intrinsic rate of the ventricles and this wide QRS morphology. Well, that's the end of this lecture. We discussed accelerated idioventricular rhythm, including its origin, mechanism, potential causes, clinical significance, and EKG features. I hope you learned something.